So we really think that patients have this need to cross-border access because we would like to have all the trials available in the world in our center, but it is not possible. So we know that we have some trials, but other centers have more, and that's the case for Aldebaran has much more trial than we have, and sometimes they have trials that we don't. So that's why if we know that, we try to, and if we have patients that we know that can be eligible, especially for biomarker-driven clinical trials, and we have a regular discussion of case in our molecular tumor board. So our precision oncology program screening detects a lot of cases that could be eligible for biomarker-driven trials. So when we have some kind of patients and we do not have clinical trials at our center that address that specific mutation or that specific alteration with a targeted treatment, and we know there is somewhere else a trials with that treatment, we would really like to send the patient for this treatment, especially because the case we discuss in our molecular tumor board are patients that are over the standard of care treatment, so they are last line approved treatment for them, so they won't have other option afterwards. So, or that is not something that they already have done, or something with no evidence to be effective. So that's our priority is to have clinical trials for them.
What we have established for 3 years now is that we have regular mutual meetings every 2 weeks, provided that there are cases, and we discuss those patients that you have identified in your molecular tumor board as having alterations that are clinically relevant. So the good thing is that we also have tools to identify the clinical trials that we have in our institution. So even if the clinical trial is not in our department, in the phase 1 unit, and they are in a specific group from Porto, they can identify it, flag it, and we review the inclusion criteria, and we are also facilitate the contact details with the physicians in charge of that study.
It depends, because actually we have our own IPO Porto molecular tumor board, and then we have a small molecular tumor board in between us, faster, with just the patient that we already pre-selected, and because we know that they are, for example, willing to travel, and so normally younger patients and with best performance status. So there are very few patients in not all the patients that we discuss in molecular tumor board at our institution. And the other thing is that this is this pre-selection, or at least check if the trial is really ongoing in their center. So if I hope that they will have this trial, I select the patient. And so it could be in between 5 and 10 per meeting we have. Sometimes yes. 10 is the maximum, maybe.
Yes, I think that was after the
after
holidays.
Yes. Yeah. So, but I can say 4 or 6 patients.
Exactly.
In each 2 weeks.
Every 2 weeks. So one of the good things is that the Porto team always asks for the eligibility criteria. So they already check that the patient meets all the analytical requirements, so that the blood work is correct, because sometimes, especially if they are very phase 1 clinical trials, that is when the patient receives for the first time a treatment, they are quite picky on the requirements for blood work, of liver function, or mineral salts. So that's one of the works that they do an excellent job. And then usually what we do is first we talk to the referring physician, if it's not one of them, and then we usually organize a telephone interview with the patient. So that way we explain what the clinical trial is, we explain some of the data of the informed consent, we share by email the informed consent, so that way there is some work done before the appointment with us.
Yeah, so we are a little bit more sure that the patient doesn't go there and then fail at the. It could happen as screening failure, but we try to don't avoid unnecessary dislocations. Actually, we do this before, so we just discuss the patients that already said that they are willing to. So that's why I was saying normally are younger, are more, willing to try another option that is not available here, because that's the big point. We do this because we do not have here.
So logistically, there is a big variability depending on the kind of clinical trial. So all the procedures within the clinical trial are covered by the sponsor, but the amount of funding for the trips or for the housing depends. So we have from some sponsors that are able and willing to organize the trips and the hotels by themselves, to academic clinical trials that are funded by academic groups that have very limited funding or no funding. So it's something that we explain in that previous visit to the patient, because unfortunately we know that it's a cost that they need to undertake. Even if there is a reimbursement, they need to be able to face with that cost up front. So far we haven't had any limitation with the patients that have been referred so far. And then an advantage is that many patients in Portugal speak, read, and understand fluently Spanish, which facilitates the informed consent process. So that way we avoid the limitation of the translation of the informed consent and approval by the ethics committee that in many cases may delay having the access to that study. And then the patients come and we give them the freedom based on that coverage if they want to stay, if they want to go back and forward. Because at the beginning in a phase 1 clinical trial, the visits can be like every week, and then they tend to get better. We also have good connections with flights with Portugal, which also facilitates.
Actually, yeah. Okay. And but so the case, the majority of them, they travel back and forth. So they just book the hotel and then they stay some more days when is the initial phase, as Irene said, but then come back to Porto. So they don't live there for this. It depends, but the thing that we do it, the clinical trial unit always talk before with the medical oncologist here in IPO Porto to check the eligibility, and then we exchange contact in between the medical oncologist of this patient and the principal investigator or another sub-investigator of the clinical trials back there in Barcelona.
Exactly.
And then they directly communicate if they need some additional report or something like that. But the visits are during the period of the trials. They don't need to come here if they are treated there. So they come back when they.
Exactly, but it's true that many times they keep having phone calls with the patients. And actually, another story of success is that the physicians here have been so helpful. So every time that we need pain medication adjustment, they are supportive, transfusions, and especially if, that there are some safety tests that we call in the clinical trial. So basically blood works that you want to check how is the liver function test. Is not mandatory. If it was a patient that was living in Barcelona, probably will come in 3 days' time. So here we have a lot of flexibility in that sense because we have very good communication, and the team from Porto
That's the point.
provides great support.
Also the oncologists here are aware that we are trying to do this, so we are. But a lot depends on the communication, so we really have to.
Obviously, things can be improved. I think if it was easier to do the translation bit in a faster way and not consuming resources for the academic consortiums or for the small biotechs, more patients would have access. Also, having support to cover the trips, because we really believe we are in countries where we have public health systems, so we think that health is a right for the patients. And we really think that if unfortunately you have a cancer, but that cancer has an alteration that has proof to have a treatment that can help you, we should try to facilitate to the patients. So definitely we think that we should have more funding to support these travel expenses from the government, from the charity association, because I think it's a key point also to improve.
No, that only is a short comment, because this is working because of us, actually. So it would be really nice to see if we can do it with other centers, and we try to do this, and they are also available but especially for example, we have more concern if the center is private, for example, because because of expense, additional expense that the patient could be worried about. So that's why the financial support, especially for academic, because when there is a pharma industry sponsored trial, they don't make that much difference for them if the patient comes from another city in Spain or in Portugal, because the expense can be almost the same. But when it's academical, as Irene said, the funding are less. So, but the right trial could be an academic one. As your basket, you have a lot of treatment available there.
Okay.
And a last point that I think that from the regulatory perspective, something that could help tremendously will be to have the centralized studies. So the patients do not need to come to the center to have their regular checkups, the blood work, but you can use the ones from your institution. And we start having some studies that since COVID at least accept the blood work from other centers, and especially if it's a reputable center like yours, like a comprehensive cancer center. But I think that there is room for improvement there too.
Yeah, especially for phase 1, that will be the last one that would be decentralized, right? So
I think we covered a lot of topics, so thanks a lot, and good to have you again.
Thank you very much.